Okay, let's continue with the most common infectious diseases. Here we have infective endocarditis. What does that mean? It's an infection of the heart valve, endocardial surface, or an indwelling cardiac device. So it's an infection within the heart valve or the surface or the device. The patient might have fever as well as murmurs. Diagnostic methods include blood culture, a transesophageal echocardiography, or transthoracic echocardiogram. Generally, the duration is so long, it's between 4 to 6 weeks. So when treating the patient empirically, we have to keep in mind either is it native valve or prosthetic valve, because this will change our treatment options. In such cases, when we have prosthetic valve, we might add rifampicin. Okay, so let's look at each one individually. So when we have infective endocarditis with native valve, and the causative agent is very dense streptococci, we can give the patient penicillin plus gentamicin or ceftriaxone. Same thing when we have native valve, but this time we have staphylococcal species. And this is very common in patients who are IV drug users, because as you can remember from the normal flora picture that I showed you before in the first section of this module, we saw that the most common causative or normal flora is staphylococcal in the skin, and people who are injecting themselves, they might inject this type of bacteria, which might eventually seeds in the heart valve. So it's very common type of infection in patient or causative agent in patient who are IV drug users. Anyhow, we could either have methicillin sensitive Staph aureus, and you can remember we can treat it with either anti-staph like cloxacillin or cefazolin, which is the first generation cephalosporin that covers MSSA. Or we can use, if it's MRSA methicillin resistant Staph aureus, we can in this case use vancomycin. So it's either MSSA or MRSA, and we don't have to add gentamicin in such cases. When we have prosthetic valve, we will treat all the same. When we have Staph epidermidis or other coagulase negative staphylococcal or very dense streptococcus, we will deal with all of them the same. We either use cloxacillin plus gentamicin, or vancomycin plus rifampicin plus gentamicin, or cefazolin plus rifampicin plus gentamicin. Last but not least, either when we have a Hayseck group, either in native or prosthetic valve, we will treat the same. We can use either something that covers gram-negative like ceftriaxone, ciprofloxacin, or ampicillin. And that was for infective endocarditis. Moving now to community-acquired pneumonia, which is the most common type of pneumonia. It is mostly caused by bacteria. Signs and symptoms include, but not excluded to, productive cough, chest pain, and rales that you could hear when you do the test. Diagnostic methods include blood culture, sputum culture, and X-ray. Treatment duration is between 5 to 10 days. When you're treating a patient who is coming with community-acquired pneumonia, keep in mind I'm talking about only community, and this is not hospital-acquired pneumonia. We have select the patient either as outpatient, inpatient and ICU, or inpatient ICU. And all of this depend on their presentation. Let's say you have a patient who is previously healthy, outpatient, no antibiotic used in the past 3 months, and coming with signs and symptoms of pneumonia, you will treat this patient as outpatient, and then you suspect Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, or atypical. In such a healthy patient who is outpatient, you can use either macrolide like azithromycin or doxycycline. When I have a patient who is coming with comorbidities or antibiotic use in the past 3 months, however, he fits the criteria for being outpatient, we suspect the same organism. In this case, we have to treat both. The idea is to cover both atypical specifically and Streptococcus pneumonia. So we have to use macrolides and add to it beta-lactams, or use the respiratory fluoroquinolones by itself. And remember, the respiratory fluoroquinolones are gemofloxacin, moxifloxacin, and levofloxacin. We call them respiratory fluoroquinolones because they cover Streptococcus pneumonia. Okay. Same thing with inpatient non-ICU. Sometimes the patient might be severe cases that we need to admit the patient, but to the non-ICU unit, to the general ward, for an example. We deal with it the same as outpatient with comorbidities, beta-lactams plus macrolides or respiratory fluoroquinolones. Last but not least is the inpatient ICU admission. So this is very severe patient coming with community acquired pneumonia, and we need to admit to the ICU. In such cases, we suspect, beside what is here, Pseudomonas, MRSA, and Legionella. So we could use, if we are suspecting only Streptococcus, we could use the same as inpatient non-ICU, which is beta-lactams plus macrolides or respiratory fluoroquinolones by itself. If we suspect Pseudomonas for any reason, we have to give anti-Pseudomonas, and you remember example of anti-Pseudomonas included piperacillin tazobactam, ceftazidime, cefepime, meropenem, some fluoroquinolones, and etc. Also, if we suspect MRSA, we have to cover with an agent for MRSA such as vancomycin or linezolid. So that's it for the pneumonia. We have to keep in mind, is it outpatient, is it inpatient, or inpatient ICU? Outpatient healthy, macrolides or doxycycline. Outpatient non-healthy or inpatient non-ICU, beta-lactams plus macrolides or respiratory chloroquines. Inpatient ICU, we might keep Pseudomonas or MRSA in mind.